The clinical question that we're answering today is often deemed very difficult, especially by radiologists who are trying to look at the images, is brachial plexus imaging. Often these patients present with pain, and often they're disappointing because you can get images that don't really show many reasons for that pain, and there's a lot of challenges that come with that area that cause that. There's a number of challenges in that area. One is the shape of the body. You've got a narrow neck with broad shoulders, and then you've got the air and the lungs that come up, the apices below it. The other thing is you're looking at nerves that are surrounded by blood vessels. Those blood vessels have pulsatile motion, which can also create little artifacts around the fine detail that you're looking for in the nerves. The other thing is the patient is breathing, and we can't stop that for scans as many times as we'd like to temporarily. But just breathing motion itself, and depending on what body type you have, that can be much worse in some than others. So 3D NerveView is, from the basic construction, a 3D stir, but it has prep pulses called MSDE pulses, which suppress the blood flow through these nerves to really make the nerves stand out without artifacts around them. As a sequence, it's actually very basic to use. All the tools of the sequence are inbuilt. We just got to make sure that we're covering the area that we need. We just place it. It's very easier from a user perspective to use. The very encouraging thing about this sequence is instead of just the brachial plexus, we can actually use it outside the brachial plexus as well, and we're getting good nerve view imaging of the periphery and other parts of the body. But for the most difficult part of the body, I think this has been an invaluable tool that we pretty much, from a referrers and patients' point of view, is something that we couldn't go without these days. Well, the beauty of that is essentially most 3D scans covering the huge region that we're often covering, especially on a wider patient. I think we're still finding our way with compressed sense in the sequence. If I was to look at the biggest impact that this sequence has on patients, it's often getting an answer to something that they've been searching for a long time. A lot of these pains are long-term peripheral neuropathies or some sort of neuritis. They've had previous imaging, sometimes of other modality like ultrasound, and there's no structural reason for this to happen. I think the sensitivity of the nerves to show bright signal from neuritis or neuropathies in the sequence is quite sensitive, and there's been multiple recent occasions where we're getting true answers that fit the clinical story to the patient and give the referrers and the patient a lot more confidence that we're actually localising exactly where their problem is. So if to look at 3D NerveView in a nutshell, essentially we're scanning a very difficult part of the body. We're taking away a lot of the artefacts that we're getting from the usual challenges, especially blood flow and breathing artifact, and a very uniform signal robustness across a very broad area. Having multi-transmit in the, especially in the 3T platform, is certainly helping this along, but it's like a one-stop shop for brachial plexus imaging, and the diagnostic confidence to both the referrer and the radiologist is vastly improved. And from a technologist or a user point of view, something very easy to implement. Compressed sense has made it a very feasible scan time for the amount of detailed information that they really require. And so I think we've got a very good combination of a lot of factors joining together for a difficult area. Most recently, the last couple that have come to me have had multiple episodes of routine scanning with no real result in the report giving them an answer as to where their pain is directly coming from. Often these pains are referred all the way down their arms or up and through their neck, and it's very hard to pinpoint exactly the area of treatment that's required. Having patients very emotional about the fact that we find a specific area that has not been able to be seen before is certainly not just making them very excited, but the referrers are a lot more excited because now they've got something to point at, something to treat, and something to show the patients that we've definitely got somewhere to show you that's causing the pain and somewhere to start with the treatment. When we look at these images, you can see that the routine imaging there, we get very, very beautiful sharp imaging. We're using advanced TSE, we've got multi-transmit, we've got everything going for us here to make extremely high quality, detailed images. The challenge is still depicting, the forest and the trees. Looking at the subtle details within nerves is very tricky. So being able to suppress blood vessels, breathing, and all the background tissue with this 3D NerveView, you can see a very uniform set of nerves that go across both sides. So then we can be very confident that if we see an increase in signal, we know it's going to be something genuine. I can't tell you how excited the referring surgeon was that we were able to show exactly not something that just matched the story, but something that was so well defined. Well, the exciting thing about this technique and some of the modifications that we've played with If you were to consider what most people have looked at with imaging the nerves in this area, you sort of see a generalised pipe of nerve going through. I think if you were to use an analogy of an electrical cable that has a grey exterior and cords within it, you've got your positive, negative and your earth. If you were to suppress the outer layer and see the inner layers of nerves, seeing the individual components of the nerves to me is really exciting, and we're definitely seeing that finer detail, subsheath sort of regions that we've never been able to see before. And I think that's going to continue to improve with further modification of this beautiful sequence. So here we have another great example of exactly the same sequence, but in the peripheral part of the body, looking at the radial nerve coming down from the elbow there. This is an area that we're commonly asked to scan, and we commonly don't see any consistent sort of significant pathology that would be an obvious reason for these. Often the radiologist may be looking for any thickening of the nerve or other sorts of little signs that there's going to be some irritation there, and often they can show a little bit of fluid in the joint or a reason that the nerve might be irritated. But directly seeing that the nerve is inflamed is something that is very new, and something that has become a very diagnostic confidence builder for both the referrer and the radiologist. I think the ability to being able to use the best equipment, the best sequence abilities, the best parameter abilities, and empower ourselves with improvements constantly is the reason that we get up. It's the reason we love what we do, and I think if we were just sitting there pressing buttons all day, it'd be pretty mind-numbing. And I think working with the best equipment and the new innovations that are constantly coming is probably one of the most rewarding things about doing what we do.